Hello everybody. Today we are going to discuss about the mechanical ventilation. So there are two types of mechanical ventilation, non-invasive mechanical ventilation and invasive mechanical ventilation. Non-invasive mechanical ventilation, in this positive pressure ventilation is delivered through tight fitting face masks. Patient should be conscious and coherent. It is initially preferred method in type 2 respiratory failure and there is less risk of pneumothorax and ventilator associated pneumonia. So this invasive or conventional mechanical ventilation is also positive pressure ventilation, which is delivered through endotracheal tube. The airway is secured. There are less chances of the aspiration. Preferred method and can be done in the unconscious state, especially in the type 1 respiratory failure. And if patient is not responding to NIV, then invasive mechanical ventilation is done. So non-invasive ventilation, it is the best used as short-term therapy to buy time to medical therapy. It means to support the failing respiratory function by delivering oxygen-enriched gas under pressure without requiring ATT. It is usually provided by using tight-fitting face mask in the nasal mask, similar to the mask traditionally used for sleep apnea. It has proved that it is highly effective in patients with respiratory failure from acute exacerbation of COPD and is most frequently implemented during using BiPAP ventilation and pressure support ventilation. So there are two types of NIV, that is CPAP and BiPAP. Both are using the continuous pressure. CPAP, the pressure is same during inhalation and exhalation. It is used during the cardiogenic pulmonary edema post then mild to moderate sleep apnea. BiPAP is used in the BiPAP is also continuous pressure, but pressures are different during inhalation and exhalation. So it is used in acute hypercapnia, cardiogenic acute pulmonary edema, immunocompromised patient with infection. So ventilator breath types. Ventilator derived breath can be controlled or assisted. Control breath is initiated by the ventilator, pressure support, pressure volume and preset pressure. Assisted breath is initiated by patient and assisted by the ventilator. Now we'll see what is volume control. In volume control ventilation, the same pre-specified tidal volume is delivered with each inspiratory cycle, regardless of whether the breath is time or patient triggered. The key provider setting include flow rate, tidal volume, respiratory rate, PEEP, and F out. Depending on the ventilator, the user will input either flow rate in the tidal volume or inspiratory rate or tidal volume. So in volume control ventilation, the pressure is not controlled. It is dependent variable determined by the airway resistance and the lung compliance. As the resistance increases and compliance worsens, the flow will remain constant and the pressure will rise. So advantages of volume control ventilation include guaranteed tidal volume, stable minute ventilation, the ability to specify flow rate, which could be advantageous in setting of high airway prayer resistance. Disadvantages are injurious pressure that may be generated in the setting of worsening lung compliance and high resistance. So these are the various variables defining common ventilator mode. So these modes are volume control, pressure support, and pressure regulated volume control. Details we'll see. So this is volume control waveform. Now we'll see what is pressure control. Pressure control ventilation, constant inspiratory pressure is applied throughout the inspiration, regardless of whether ventilator or patient initiates the breath. The key provider in this setting are inspiratory pressure, inspiratory time, respiratory rate, PEEP, and F out. Depending on ventilator, the user will input either total inspiratory pressure desired or inspiratory pressure to be applied above PEEP. In this mode, the flow and the resulting tidal volume are dependable variable and can vary with the changes in the airway resistance and lung compliance. So one advantage of the pressure control is that airway pressure and pulmonary pressure never exceeds the selected inspiratory pressure. So the risk of barotrauma is minimized. Another advantage is that control their inspiratory flow rate, airflow will increase in proportion to the inspiratory effort, improving patient comfort and minimizing patient ventilator desync. A disadvantage is that a delivered tidal volume can vary. As resistance decreases or compliance improves, the same pressure may lead to excessive tidal volume. Alternatively, if a resistance increases and compliance worsens, the same pressure will generate much smaller volume and results in poor ventilation, carbon dioxide retention, and ventilatory failure. So, this is the pressure control waveform. Pressure regulated volume control, it is the mode of mechanical ventilation that uses adaptive targeting scheme to automatically adjust inspiratory pressure to achieve pre-specified tidal volume. So the key provider setting include targeted tidal volume, inspiratory rate, respiratory rate, PEEP, and FI. The commonly used name for this mode, PRVC, is misleading. So flow and volume are not controlled. Pressure is control variable and flow varies with changes in the airway resistance, lung compliance, and the patient effort. And this is a graph of pressure regulated volume control. To achieve target tidal volume, PRVC monitors the tidal volume resulting from applied inspiratory pressure. So if the tidal volume is higher than the target, the applied pressure for next breath is decreased. If it is less than the target, the applied pressure is increased for the next breath. So in this way, the PRVC allows for breath-to-breath pressure adjustment to achieve desired volume in the face of changing resistance, compliance, and the patient effort. So PRVC theoretically provides benefit of variable flow from pressure control with guaranteed minute ventilation of volume control without requiring the user to adjust the inspiratory pressure. The disadvantage of PRVC is the potential for patient ventilator dysynchrony in patients with high respiratory drive. If patient develops increased work of breathing and is generating large tidal volume at a given inspiratory pressure, the adaptive targeting scheme will continue to reduce inspiratory pressure with each subsequent breath. This results in less support from ventilator and increasing patient work of breathing. PRVC should therefore be used in patients who have stable respiratory tract. Now about advanced mode of ventilation, airway pressure release ventilation. Airway pressure release ventilation entails continuous positive airway pressure at high level with intermittent time cycle release to maintain alveolar recruitment and the lung volume. So patient can breathe spontaneously independent of phase of respiration through biphasic positive pressure circuit. This allows the movement of posterior part of the diaphragm, increasing distribution of ventilation to dependent posterior lung region, improving ventilation perfusion matching as compared to the movement of anterior tendinous region of the diaphragm during control mechanical ventilation. So APRV was initially described as spontaneous mode of ventilation to treat patients with acute lung injury with aim of maintaining low airway pressure and to allow unrestricted spontaneous ventilation. There are some reports suggesting APRV may prevent progression of acute lung injury in high-risk trauma patients. So APRV was also shown to be effective in reducing CO2 as well as improving oxygenation without increasing minute ventilation in conjunction with the reduction in peak and the mean airway pressure. Improvement in the gas exchange with APRV is related to the reduction in dead space ventilation. The use of APRV, however, is not widespread and this mode is not available in all commercially available ventilators. Furthermore, improvement in survival with this mode of ventilation remain to be evaluated. Now the next is adaptive support ventilation. Adaptive support ventilation is the closed loop control ventilatory mode, which is designed to ensure optimization of the patient work of breathing, automatically adjusted according to the patient's requirement. ASV combines the passive ventilation with pressure control ventilation with adaptive pressure support if patient's respiratory effort is present. ASV delivers pressure control breath according to the set minute ventilation, resulting in best combination of tidal volume and respiratory rate. As patient's inspiratory efforts start, ASV delivers pressure supported breath according to the set minute ventilation, resulting in best combination of tidal volume, respiratory rate, and the patient's inspiratory effort. In ASV mode, FiO2 and PEEP are set manually. Now, intelligent ASV. Intelligent ASV is also closed loop ventilation that adds the monitoring of SpO2 and pressure and tidal CO2 to best manage ventilation and oxygenation. In intelligent ASV mode, the clinician sets the patient's sex, height, and choice the following respiratory mechanic situation. That is normal ARDS, chronic hypercapnia, and brain injury. Intelligent ASV determines the target PET CO2 and SpO2 according to the patient's condition. So in ventilator controller, adjust the best tidal volume and respiratory rate to achieve minute ventilation and PET CO2 set by clinician combining pressure control and pressure support ventilation according to the patient's inspiratory effort. In intelligent ASV, FiO2 and PEEP are adjusted according to the patient's SpO2 following PEEP FiO2 table. Now, Smart Care. Smart Care is the automatic weaning protocol designed to stabilize the patient's spontaneous breathing in comfort zone of pre-test defined ventilation and to automatically reduce the ventilatory support. Smart Care ventilates the patient with pressure support, which levels are adjusted according to respiratory rate, tidal volume, and end tidal CO2 to meet patient's demand. Smart Care classifies the patient a minimum of every 5 minutes into one of the 8 categories, decreases or increases the pressure support level accordingly. So, Smart Care assesses and indicates the readiness for extubation after successful automatic spontaneous breathing trial. Now, next is volume assured pressure support ventilation. It is a dual mode of mechanical ventilation that associates pressure support ventilation to volume assisted ventilation. This combination optimizes the inspiratory flow, decreasing the patient's work of breathing while assuring the safe tidal volume. Compared to the volume assisted ventilation, volume assured pressure support ventilation can decrease the patient's respiratory drive in the pressure time product and the patient's work of breathing. This advanced mode of ventilation extends the benefit of PSV to unstable patient with acute respiratory failure, assuring pretest tidal volume. This is this graph of volume assisted ventilation. Now next is NAVA, neurally adjusted ventilatory assist. It is a mode of mechanical ventilation delivering pressure in response to the patient's respiratory drive measured by electrical activity of the diaphragm. Initially described in 1999, the NAVA introduced new dimension to mechanical ventilation in which patient's respiratory center can assume full control of magnitude and timing of the mechanical support provided, regardless of changes in the respiratory diet. This technology helps to decrease the risk of hyperinflation, respiratory alkalosis, and hemodynamic impairment. This is the schematic representation of NAVA. Then the next is proportion assist ventilation. Proportional mode deliver the assistance in proportion to the patient's demand, allowing variation of inspiratory pressure and avoiding diaphragm excessive loading and atrophy by use. Proportional assist ventilation. It is a form of synchronized ventilator support in which ventilator generate the pressure in proportion to the instantaneous patient effort or in proportion to flow and volume generated by the same. Therefore, the ventilator allows at any time during inspiration airway pressure in proportion to pressure generated by inspiratory muscle and respiratory mechanics. Thank you, guys.